stages. But developmental, you are born with it. So it's usually a cause. The developmental is usually part of the syndromes. So maybe the child may be born with some special defects and all that. They may also have seizures. They may also have cognitive issues and all that. So that is a syndrome. And the moment you have a syndrome, you're epileptic.
Yes, please. Thank you.
Okay. Any other question? All right. So let's look at the clinical manifestations. So clinical manifestations of a seizure. So what do you observe or what do you see when someone is having a convulsion? What are some of the signs and symptoms you are likely to see?
Biting of tongue and lip smacking.
So you can have the biting of tongue and lip smacking. What again?
Urinary and fecal incontinence.
So you can have urinary incontinence, also fecal incontinence. What again?
Foamy.
Yeah, so you can have foaming in the mouth. So hypersalivation. What again?
Sometimes they shout.
Okay. So you can have that. Any other?
Episodes of blinking or chilling at inordinary times.
I didn't get to come again. Can you come again? I didn't hear you. Okay. Any other?
Confusion and disorientation.
Yeah, so confusion. Confusion is very common. Any other?
Mood changes.
Yeah, you can also have mood changes. Okay. Any more?
Abnormal sensations.
Abnormal what?
Sensations.
Okay. All right. Any other?
Patient experiences aura.
Come again. I didn't hear.
Patient experiences aura.
All right. So there may be certain early warning signs. So that's the aura phase. Okay. Any more?
Difficulty in breathing.
Difficulty in breathing. Okay. Any more?
Paralysis.
Yeah, so paralysis. So after an episode of a seizure, it can lead to paralysis. So the patient may be having seizure on the right part of the body and after the episode, they can have paralysis on that part of the body. How do you term that type of paralysis?
Thoughts paralysis.
Yeah, so thoughts paralysis or thoughts palsy. Okay. Any more? All right, so basically, these are some of the signs and symptoms, aside the usual ones that we know, the jerky movement, the rigidity, because these are the core ones. So the jerky movement, the rigidity, loss of consciousness. Then you come to fecal incontinence, urinary incontinence. They can have paralysis. They can have confusion. They can have salivation, hypersalivation with foaming of the mouth, biting of the tongue, lip smacking. All these are some of the things that you look out for. So in the history taking, you want to be asking some of these questions, usually from the bystanders or the witness. So the phases of a seizure. So there is the oral phase, then you have the ictal phase, which is the seizure itself, then the post-ictal phase. So you have the oral phase, which is more like the prodromal phase, then the ictal phase itself, which is the seizure, then the post-ictal, just after the seizure. So these are some of the things that you look out for in the face. So you want to find out from the patient, usually the aura, if there's any signs of aura. And basically the aura phase are the early warning signs the patient may pick up before the seizure itself starts. And usually the patient may have abnormal sensations. So there may be abnormal smell. So it may affect how they smell. So they may have this abnormal smell. They may also have flashes of light. So vision issues, so visual disturbances, then flashes of light. They may also have mood changes. So they could also have mood changes prior to. So all these are the aura phase. And they could also have deja vu. So deja vu, where they have this feeling of an impending doom and all that. So these make up the aura phase. Then the ictal phase is the seizure itself. So the seizure itself, we've talked about the focal, the generalized onset and all that. So that's the ictal phase. And after the seizure, when the seizure has aborted, the phase right after is the post-ictal phase. So after a seizure, so post-ictal phase. Usually this is where the patient may have this confusion and all that. So that's the post-ictal phase, right after a seizure, because they may not be aware of the environment, the people around them. So they have this short confusion bit. Not all the seizures follow this pattern. Some of the seizures do not have any aura phase. They just start as the ictal phase, then post-ictal. And some of them, you wouldn't have a post-ictal confusion and all that. After the seizure, they regain consciousness back to their normal activities. Some do not even realize they have a seizure, especially the absence seizure, because these are usually seen in children, and the teachers or parents tend to pick it up because they feel like the patient is not concentrating in class. So they may misdiagnose it as attention deficit disorder. because there's always that short spell where they lose consciousness and all that. So, in terms of the clinical manifestations, these are some of the things that you should be looking out for. Any questions? Okay. So the aura phase is usually more common with focal seizures. So you usually wouldn't have aura with generalized, unless it's focal evolving to generalized. So aura is usually seen with the focal seizure. So either focal aware or focal with impaired consciousness. This is where you usually have the aura. So let's take note of that. So in terms of what is actually happening, the pathogenesis is very simple. So we are looking at neurotransmitters in the brain. So we have what we call the inhibitory neurotransmitters and the excitatory neurotransmitters. So basically, the inhibitory neurotransmitters, the major ones, GABA and glycine. These are the major inhibitory neurotransmitters. Whereas the excitatory neurotransmitters, we have glutamate, we have aspartate, and we have acetylcholine. So these are excitatory neurotransmitters. Ideally, they keep each other in check. So there's some sort of equilibrium which is supposed to keep each other in check. And that prevents the abnormal firing in the brain. However, if there is anything or any condition that is causing the excitatory arm to be upregulated, then a seizure would occur. So if you have the glutamate, aspartate overfiring, then you can have a seizure occurring. Or you can have a reduced inhibitory effect. So either GABA and glycine levels are down, then you can have a seizure occurring. So that's the basic pathogenesis. It's either the excitatory arm is upregulated or the inhibitory arm is downregulated. So that's how a seizure may come forth. To be able to diagnose this condition, the first thing you want to take is your history. With the diagnosis, the first thing is the history. You want to find out when did it start, how did it start. And usually the history is best taken from bystanders or witnesses, because the patient himself may not be aware of whatever is actually happening because they've lost consciousness. So they are usually not the best people to take history from, unless maybe it's a focal aware seizure. The patient didn't lose consciousness. They are aware of everything is happening. For such patients, you may want to take history from them. Even that, you still want to confirm from bystanders or witnesses. So history taking is the first thing. So you want to know the onset. How did it start? Is it just on one part of the body? Is it just is it evolving the two parts of the body, or it started on the left part, progressed to all parts of the body, or the right, progressed to all parts of the body? So here we want to know how the onset came about, whether it's focal onset, generalized onset, or unknown onset. Then you want to further ask how it manifested, whether there was jerky movement, there was rigidity, there was sudden loss of muscle tone, for which reason the patient fell, there was sudden momentary loss of consciousness and all that. So these are key questions that can help you tailor to the type of seizure. So if they tell you there was no jerky movement, but it's just rigidity throughout, then you know it's a tonic seizure. If it's interspersed with a clonic phase where there's jerky movement, then you're thinking of a tonic-clonic. So all these are some of the things that you want to find out in the history. Aside the history, you also want to do clinical examination. So for the clinical examination bit, this is where you want to check for signs of seizure. So maybe whether there's lip smacking, whether there's tongue bites, whether there's foaming in the mouth, whether the patient has urinated on themselves, so urinary incontinence, fecal incontinence. You want to check for some of these things. So that's the clinical examination bit. Based on your clinical examination and the history, it's enough to diagnose the patient as having a seizure. Based on your clinical examination and history, you don't need any further investigation. You can tell whether it's a seizure or not. You don't need to do any imaging or any higher investigation. So seizure is basically a clinical diagnosis. So you can make that diagnosis clinically with your history and examination. However, before you can say someone is epileptic, you want to rule out provocators. So if you say epilepsy is recurrent, unprovoked seizures, so you want to rule out the provocators. So this is where you want to do the other labs to rule out the provocators. So your full blood count to rule out any infection, your CRP, your ProCal to rule out any infection. You can do your electrolyte imbalance. So you can do electrolyte check to rule out any electrolyte imbalance. So hyponatremia, hypernatremia, hypocalcemia, magnesemia, and all that. So you want to rule out any electrolyte imbalance. You can do your glucose monitoring to rule out hypoglycemia, hyperglycemia. So all these are some of the things that you want to do to rule out provocators. If you are convinced there is no provocator and the patient is having recurrent unprovoked seizures, then you can say the person is epileptic. There are certain patients who may have a seizure but wouldn't have a convulsion. We said convulsion is the physical manifestation of a seizure. So they may be having abnormal electrical activity happening in the brain, but it's not manifesting for you to see as convulsion. So there's no jerky movement, there's no rigidity. But you realize, this patient, the GCS is going down, it's going down. And you are thinking, is it that the patient is having a seizure in the brain, but it's not manifesting as a convulsion? So these patients, we say they are having a non-convulsive seizure. So a non-convulsive seizure. So it's a seizure happening in the brain, all right, but it's non-convulsive. It's not physically manifested. For such patients, you may want to do an EEG. So EEG stands for electroencephalogram. So electroencephalogram. So it's just the brother of ECG. ECG is electrocardiogram, where you place these electrodes or leads on the chest, trying to look at the abnormal electrical activity. The same way, here you place the electrodes rather on the head. So we are checking abnormal electrical activity happening in the brain. So that's EEG, electroencephalogram. So if it so happens that you go in there and you are seeing abnormal electrical activity in the brain, but it's not manifesting as a convulsion, then you see the person has a non-convulsive seizure. So that patient is epileptic, all right, but it's not manifesting for you to see in terms of the jerky movement, the rigidity, and all that. You are not seeing that. So that's a non-convulsive seizure. So this where EEG becomes useful. So it can tell you the abnormal electrical activity happening in the brain, which is not manifesting for you to see as convulsion. Then there are also brain imaging that you can do, the CT or MRI, to rule out any other condition that may be causing structural abnormalities in the brain. So stroke, traumatic brain injury, all these can cause structural lesions, which can manifest as a seizure. So you want to rule out that provocator as stroke or trauma as the provocator. So you can do CT or MRI in that regard. So these are some of the investigations that you can do when you are trying to diagnose epilepsy.
Hello, Dr. Ishaq. Hello.
Hello.
Yeah, Dr. Ishaq, please, with the history taken, if a patient or someone is having an episode, can someone decide to video it and bring it to the hospital for?
Yeah, so there are instances where you are not sure what is happening. So you can take a video. So when you take a video, it's going to serve as evidence of what is actually happening. So maybe you are seeing something that looks like a seizure, but you are not sure. You can take a video so that when you get to the hospital, the doctors can interpret whether it's actually a seizure or not. And this is very useful in patients with what we call PNS. So PNS is psychogenic non-epileptiform seizures. So they are having seizures or they are having manifestations that are seizure-like, but they are actually not seizures. They are psychogenic in nature. So they may be throwing their hands, they may be having, they are turning their heads all around, and you may think it's a seizure. It may be a psychogenic non-epileptiform syndrome. So such patients, it's better you take a video evidence for the doctors to decipher whether it's actually a true seizure or it's not actually a seizure.
Okay, thank you.
Okay. Any other question? All right, so let's look at the management. So for the management, if someone should have a seizure, what are some of the first aid that you would want to provide? Assuming you meet someone having a seizure by the roadside, what are some of the first aid that you can provide? Yeah.
So I think first of all, you have to first remain with the patient for the patient to have the episode. And that will even help with the diagnosis to be able to give the history. Or again, you have to make sure that if there are any object close by that can cause harm to the patient, you take them away. And also, if after the seizure the patient is unconscious, you make sure you put the patient in a good position so that they can maintain good airway, like they'll be able to breathe well, and also secure the head. I think these are some of the things that you can do. And also, some people also put objects in their mouth too. It's not advisable for you to put objects in their mouth. So,
Okay, so you are saying that when you meet them having a seizure, the first thing is you want to look at the environment, whether it's safe, because maybe at the roadside or on the main street, cars may be passing by, someone can run him over and all that. So you want to put the patient in a safe place. So if the place is safe enough, you can allow them to have the seizure. But if it's not safe, then you can move them to the maybe the pedestrian side, which is safe from the cars passing by. Then you also want to, in terms of the head, you want to put maybe a pillow or any soft cushion under the head so that they don't sustain any injuries on the head. Then it's also not advisable to be putting these objects in the mouth with the attempt that you want to prevent them from biting their tongue or swallowing their tongue or whatever. So you want to prevent putting these objects in the mouth. Then you shouldn't restrain them. Allow them to have the seizure, all right? You shouldn't restrain them. And you should also try and time. So you keep them on the lateral side of the body so that they also do not aspirate and all that. Then you can also time the patient from the onset of the seizure. So if it's more than 5 minutes, then you know that it's no more a usual seizure. It's transcended into a status epilepticus. So it's that time you have to call for the ambulance to transfer the patient to the hospital. So it's either the seizure is aborting on its own or it has to be aborted with medication. So if it's not aborting on its own, then patient needs to go to the hospital for us to give any medication to abort it. So that's how you manage an acute seizure as a pedestrian or bystander. Is it clear? All right, so let's look at the main management. So there are
Dr.
strategies
Shak,
for
please, I have a
management.
question.
Okay, go ahead.
Please, what's the essence of putting the patient on the lateral position? Like, why do you do that?
So I mentioned that you want to prevent aspiration. So usually, you know the position of the stomach is on the left side. So you want them to be on the left side so that they do not aspirate. If they're on the right side, probability of aspiration is high. Is it clear?
Yes, please.
Okay. So in terms of the management, we are looking at pharmacotherapy as the mainstay. So there are other strategies, the surgical intervention, there is option for ketogenic diet, there is option for vagal nerve stimulation. So all these are strategies for management. But the mainstay is the pharmacotherapy. So if the patient is not responding to pharmacotherapy, then you may want to look at surgery, ketogenic diet, vagal nerve stimulation. So the mainstay is pharmacotherapy. So look at some of the classes of anti-epileptics and examples under them. So you have the sodium channel blockers. So when we're talking about the pathogenesis, I mentioned that you have the excitatory arm and the inhibitory arm. These neurotransmitters, they have special ion channels they deal with. So when you look at, for example, GABA, which is a neurotransmitter, GABA acts through the GABA-gated chloride channels. You also have other channels in the sodium channels, calcium channel, potassium channels. So these channels mediate certain inhibitory or excitatory neurotransmitters. So generally, stimulation of or influx of sodium ions, influx of calcium ions tend to cause excitatory effect. Then influx of potassium tends to cause inhibitory effect. So these are the main ion channels that we have. So the anti-epileptics tend to target some of these channels, and some also target the neurotransmitters, the GABA, the glutamate, and all that. So we look at examples of the ones that target the sodium channels. So we have the sodium channel blockers. So they block influx of sodium into the sodium channel. And once this is done, it's preventing that excitatory firing of the neurons, because the sodium channels mediate excitatory effects. So once you block it, you are inhibiting that excitatory firing occurring. So what are some of the examples that you know under the sodium channel blockers?
Lamotrigine.
Yeah, so you have lamotrigine. What again?
Phenytoin.
Yeah, so phenytoin. Any other?
Carbamazepine.
Carbamazepine. Okay. Any more?
Topiramate.
Topiramate. Yeah. Any more?
Sodium valproate.
Yeah, sodium valproate. So these are very common ones. Sodium valproate, you should know, is a sodium channel blocker. Lamotrigine, phenytoin, carbamazepine. Then topiramate. So aside the sodium channel blockers, we also have calcium channel blockers. Any examples under this class? Examples under
Gabapentin.
calcium channel blockers. Yeah, gabapentin.
Hello.
Any more?
Etosuzumide.
Yeah, so it's osuzumide. So it blocks a special type of calcium channel, specifically the T-type. So the T-type calcium channels are blocked by etosuzumide. What again?
Sulfate.
Come again.
Topiramate.
Topiramate. Yeah. Any more?
Sodium valproate.
Sodium valproate. You realize sodium valproate, when we're talking about sodium channels, it blocks the sodium channels. It also blocks the calcium channel. So it has a broad spectrum of activity. So sodium valproate, lamotrigine, they tend to have a broad spectrum of activity. They block multiple channels and they have additional benefits. So the calcium channels, we talked about etosuzumide, we talked about gabapentin, we also have pregabalin, we also have sodium valproate. So these are very common calcium channel blockers. Then we also have agents that inhibit glutamatergic activity. So we call them inhibitors of glutamatergic action. Any examples that you know? You remember glutamate is one of the excitatory neurotransmitters. So if you block that excitatory arm, you are in effect causing inhibitory effect. So that's how it exerts its anti-epileptic effect. So glutamatergic agents, any examples that we know? So So we have what we call felbamate. So I'll type it in the chat box. Felbamate, then rufinamide. So felbamate, rufinamide. You also have topiramate. So topiramate also blocks glutamatergic activity. Then we also have perampanel. So these are agents that block glutamatergic activity. Felbamate, rufinamide, topiramate, perampanel. All right. There are also agents that enhance GABAergic action. So GABA is inhibitory. So agents that are helping with GABA activity. So common examples that you know. Any common example?
Benzodiazepine.
Yeah, so benzodiazepines. So benzodiazepines are GABA modulators. What again? The brother of benzodiazepines.
Arbitrate.
Yeah, so barbiturates. So barbiturates. They are all GABA modulators. Just that the difference is benzodiazepines increase the frequency of opening of GABA mediated chloride channels, whereas barbiturates increase the duration of opening of GABA mediated chloride channels. So if it's supposed to open 5 times in 1 minute, the benzodiazepines will increase how many times it opens in 1 minute. So it can increase from 5 to 7. However, the barbiturates tend to increase the duration. So if it's opening for 30 seconds, it can increase it from 30 seconds to 1 minute. So that's in terms of the duration. So these are agents that enhance GABAergic activity, benzodiazepines, barbiturates. We also have sodium valproate. Sodium valproate also enhance GABAergic activity. Then vigabatrin. So vigabatrin, sodium valproate. Then there's also tiagabine. So the common ones are the barbiturates, benzodiazepines, sodium valproate. Vigabatrin is also available on the market. I'm yet to see tiagabine. So tiagabine is also one of the agents that enhance GABAergic activity, but it's not readily available. All right. So these are the main classes. Then we also have agents that enhance potassium channel inhibition. So inhibition of the potassium channel causes relaxation, or the inhibitory effect of potassium channel causes relaxation or inhibition. So there are agents that are going to enhance potassium channel inhibition. So take note, they are not inhibiting the channel, but rather they are enhancing potassium channel mediated inhibition. And here we have one particular drug which is known as retigabine. So it's going to enhance potassium channel mediated inhibition. So these are the main classes. Aside these, there are miscellaneous agents too. These are the new ones that are coming up. So we have levetiracetam. So levetiracetam, though, is also able to block the calcium channel, but its main effect is a ligand for the synaptic vesicle glycoprotein 2A. So it's a synaptic vesicle. So I'll type it in the chat box for you. All right, so we are saying that one is a ligand for the synaptic vesicle glycoprotein 2A. So when it binds to the synaptic vesicle glycoprotein, it acts like the ligand itself or the agent, the glycoprotein itself. So it's like an analog of the glycoprotein. And basically, it's supposed to enhance GABAergic activity. And it also has an additional effect of blocking the calcium channels. Any questions on the classes? All right, so these are some of the classes and the examples. But
Yes.
the type of seizure, is someone asking a question?
Yes, please. And please, I didn't get the name of the class for the drugs that enhance the potassium channel inhibition.
I said retigabin. I've
No.
typed it in the chat box.
The name of the class, or it doesn't have a particular name.
So the name is agents that enhance potassium channel mediated inhibition. So
Yes, please.
enhancement of potassium channel mediated inhibition.
Okay, thank you.
Okay. So you have all these agents, but the type of seizure will determine which one to choose. So we talked about the two main types being focal onset seizure and the generalized onset seizure. So there are agents that work best for the focal onset and agents that work best for the generalized onset. So you have to know the type of seizure in the first place before you choose the agent. So when you look at the generalized onset seizures, there are a lot of subtypes. So you have tonic-clonic, you have clonic, and all that. But generally, the preferred first line is sodium valproate. So sodium valproate is the preferred first line for generalized onset seizure. We talked about the fact that sodium valproate can block almost all the channels that we were talking about, the sodium, the calcium. It also has GABAergic activity. It also inhibits glutamate activity and all that. So it's broad spectrum. So for generalized onset, whether it's tonic-clonic, whether it's clonic, whether it's tonic, you can give your sodium valproate. The other preferred first-line agent aside sodium valproate is lamotrigine. So these two are the preferred first line. Just that lamotrigine has a better safety profile in terms of the side effects. Sodium valproate, it has a lot of side effects, and you also have to rule out any pregnancy in patients of the childbearing ages. So women of childbearing ages, you want to rule out pregnancy because it's teratogenic. So the issues with sodium valproate, we tend to use lamotrigine as the preferred first line. If the person is not responding, you can go to sodium valproate. Aside these two preferred first line, there are alternatives. So for generalized onset, you can also use carbamazepine, which is readily available here. So carbamazepine is an alternative. You can also do phenobab, phenytoin. All these are alternative for generalized onset. So they are not preferred first line, but they are alternative. Phenytoin, carbamazepine, phenobab, topiramate. All these are alternatives. For focal onset, the preferred first line is carbamazepine, which is readily available. So if someone presents with a focal seizure, then you want to start either carbamazepine or levetiracetam. So levetiracetam is preferred for focal seizure. Carbamazepine as well. Just that these two can also serve as alternative if it's a generalized onset, but they are actually the preferred for the focal onset seizures. So lamotrigine can also be used, and phenytoin can also be used for focal seizure. So let's take note. Lamotrigine, carbamazepine, phenytoin, levetiracetam. All these are preferred for focal seizure. The alternatives are a lot. So topiramate, sodium valproate. Sodium valproate was first line for generalized onset. When it comes to focal, it's an alternative. It's not the preferred first line. You could also have phenobab also coming in here as an alternative. Gabapentin. You could also have lacosamide. All these are alternatives for focal seizure. Depending on the particular type of generalized seizure, there are special medications for certain conditions. So if the patient has absence seizure, so for absence seizure, which we said usually occurs in children, the preferred agent is ethosuximide. So ethosuximide is the preferred agent for absence seizure. So these agents, we are looking at agents that are able to inhibit the T-type calcium channel for absence seizure. So ethosuximide can do that. The alternatives are you can do valproate and lamotrigine. So these are also first line, but ethosuximide is the preferred first line. If you don't have ethosuximide, you can do topiramate, you can do sodium valproate, or you can do lamotrigine. Then if the patient has atonic seizure, so for atonic, the preferred one is to do topiramate. So you can do topiramate, you can also do sodium valproate, and you can do lamotrigine. So these are agents that are preferred for atonic seizures. For myoclonic seizure, you can do clonazepam, which is one of the preferred agents, clonazepam, which is a benzodiazepine. You can also do sodium valproate and lamotrigine. There are also instances where, I think when we were talking about the causes, we mentioned
Hello, sir. Please, can you take the myotonic again?
myoclonic. So preferred one is clonazepam. So clonazepam is the preferred, but you can do sodium valproate as well. All right, so I was talking about for patients during menstruation. So there are certain people that will have seizures during menstruation, usually occurring 3 days before the menses or 4 days after the menses or during the menstrual period itself. And this type of seizure is what we refer to as catamenial seizures. If it keeps on happening, then you talk about catamenial epilepsy. So this occurs during menstruation, usually 3 days before menses, during the menses itself, or right after the menses, 4 days after the menses. And basically what happens is that these occur as a result of hormonal imbalance. So the hormones in females, you have the progesterone and estrogen. So the estrogen is referred to as a pro-convulsant. So if you have high levels of estrogen, it increases your chances of having a seizure. Whereas if you have low levels of progesterone, which is anticonvulsant in nature, it also reduces or increases your chances of having a seizure. So ideally, they are supposed to be in sort of an equilibrium. So anything that will increase the levels of estrogen can cause seizures during menstruation, or low levels of progesterone can cause seizures during menstruation. So this is what referred to as catamenial epilepsy. Here, the preferred agent is acetazolamide. So catamenia usually respond well to acetazolamide. Then we also mentioned eclampsia. So for eclampsia, a pregnant woman 20 weeks into gestation presenting with BPs 140/90 consistently around that figure 6 hours apart. So you've done several readings, it's very high. There's evidence of proteinuria, and the patient is also having seizures. It's no more preeclampsia, but rather eclampsia. These patients are not epileptic, but it's because of the pregnancy. So these tend to benefit from magnesium sulfate. So the preferred anti-epileptic in these agents, in these patients, are magnesium sulfate. However, you can have a known epileptic. The person is already a known epileptic and becomes pregnant. Most of the anti-epileptics tend to have teratogenic effects. So you want to avoid most of them, like the sodium valproate, the phenytoin and all that, especially during the first trimester. The preferred agents are usually lamotrigine and levetiracetam. So lamotrigine, levetiracetam. So the person can be on sodium valproate prior to pregnancy. Once they become pregnant, you can switch to levetiracetam or lamotrigine. But if they start having seizures 20 weeks into gestation, evidence of hypertension, proteinuria, it's eclampsia superimposed on someone who is already epileptic. So such patients tend to benefit more from magnesium sulfate. So these are some of the instances where you choose one agent over the other. Is it clear?
And so please, I just want to be sure. You said if a patient develops eclampsia, that's when you give the person magnesium sulfate. If the person was already like epileptic and becomes pregnant, that's when you give the levetiracetam and lamotrigine.
Yeah, so the person is already epileptic, was on his usual anti-epileptic, but because he got pregnant, these anti-epileptics cannot be given because they are teratogenic. So we are saying the safe ones are lamotrigine, levetiracetam. So you can switch to those ones. However, if the person is not epileptic, or the person may be epileptic, but the seizure is only occurring 20 weeks into gestation, coupled with hypertension and proteinuria, that is eclampsia. And eclampsia wouldn't respond to the usual lamotrigine or levetiracetam. So you'd have to put the patient on mag sulfate to cater for that.
Yes, please, sir. Thank you.
Okay. So there are instances the patient would be refractory to all these medications. If the patient is refractory to all these medications, then you consider the other strategies. So like surgery. So there's option for surgery. Usually the surgical options are lobectomy and hemispherectomy. So lobectomy is removal of a lobe from the brain. So if it's a lesion within or a tumor within the maybe temporal lobe, you can do surgery to remove that part because that's the focus of the seizure. So you can do a surgery to remove that part of the lobe. Or if it's just as one hemisphere, you can do hemispherectomy. But now some of these surgeries, hemispherectomy, they are not usually done because once you do hemispherectomy, then it affects a lot of functions in the body. So they rather prefer to do lobectomy, just a small portion of the brain. Then you move. If it's generalized seizure, it's difficult to do surgical intervention. But if it's a focal seizure, you know it's coming from this particular portion. So you can go in there and do your lobectomy. There's also option for ketogenic diet. So for ketogenic diet is very beneficial in children who are refractory to medical therapy. So here we are looking at having a diet where there's normal proportions of this one, low levels of carbohydrates, normal proportions of fat, and high levels of protein. So for these patients, you put them on this ketogenic diet. Did I mention normal proportions of proteins or high proportions of protein?
High.
Hi.
So it's rather normal proportions of protein, high proportions of fat. So you want to do a ratio of 4:1. So 4 of fat. So that's the high proportion. Then the 1 is the normal plus the low carbohydrate makes up the ratio of 1. So it's a ratio of 4:1. So 4 of fat, then 1 of the proteins and the carbohydrates. Just that the carbohydrates, you have low levels and normal proportions of the proteins. Basically, the rationale is that you want to prevent the body from utilizing carbohydrates. So you want the patient to break down the fat. And you know, breakdown of fat, you produce fatty acids and glycerol. And fatty acids, through ketogenesis, you form ketone bodies. So these ketone bodies will now serve as energy source. So they realize that these ketone bodies are able to cross the BBB. And once you have high levels of ketosis in the brain, it's able to achieve some level of anti-seizure effect. So if the patient is actively having seizures, not responding to medical treatment, ketogenic diet can be used as an adjunct. And in this case, high proportions of fat, which is a ratio of 4:1, to normal and low levels of normal protein, low levels of carbohydrates. The state of ketosis, which is achieved in the brain, is the one that's going to help with the seizure and aborting of these seizures. So if the patient is not responding to medical therapy, you can do ketogenic diet, but it's more helpful in children. It's usually not routinely used in adults. Any questions?
Please, can you go over the ketone bodies one again, please?
I was talking about a high proportion of fat, which is a ratio of 4:1. The 1 is normal proportions of proteins and low levels of carbohydrates. And the rationale is you want to shift the energy utilization from carbohydrate to fat. So the body will break down fat, and fat will be broken down to fatty acids and glycerol. You know, glycerol utilized in gluconeogenesis. The fat will be broken down through ketogenesis to ketone bodies. And these ketone bodies are able to cross the BBB, get to the brain. Once you achieve that state of ketosis in the brain, it's able to cause inhibitory effect. And that inhibitory effect will cause the seizures to abort. So that is an option for refractory seizures not responding to the medical therapy in children.
Thank you.
Dr. Ishak, is it advisable or can you do this ketogenic diet with the pharmacotherapy at the same time?
Yeah, you can use it as an adjunct to the medical treatment. So usually it's not effective alone as a standalone. So you usually want to do an add-on to the medical treatment.
Okay.
Any more questions?
Isaac,
Yeah.
please. I also heard that when somebody is having an episode and they're foaming, if the fluid touches your body, you to become epileptic. Is it true?
No, it's not the case. It's not the case. It's a myth surrounding epilepsy, and they use that to stigmatize them. So if someone is having a seizure and you realize they all are moving away and trying to stigmatize the patient, so it's not a true statement.
Dr. Ishak, also with the refractory seizures, while exploring the other options, do you still keep the patient on the medications that he or she is not responding to? Or you stop those completely and then explore the other options of management?
Yeah, so most of the times the other options are more like adjuncts. The mainstay is the pharmacotherapy. So you want to still keep the patient on it, then explore the option of ketogenic diet in addition.
Okay.
Hello. Hello, no.
Yeah.
Please, with children, after seizures, you see sometimes they have secretions in the nostrils or vomiters in the nostrils. Is it advisable to suction them out?
Yeah, so you have to suction, because if you don't suction, some of these foaming and all that can cause aspiration. You know, aspiration is not just gastrointestinal content, getting reflux and all that, but sometimes oropharyngeal secretions. So these oropharyngeal secretions can find their way into the airways, and that can also cause aspiration. So it's advisable that after you suction them to prevent all these complications.
Thank you.
Hello.
Dr. Shak.
Hello.
Yeah, please, how do you
As
manage the psychogenic seizures?
Yeah, so the psychogenic seizures, they are usually as a result of an underlying psychogenic condition. So you'd have to find what exactly is the psychogenic underlying cause. So they may be having schizophrenia, they may be having any of these psychotic disorders. So you have to manage the underlying disorder. But aside that, they tend to respond to some of these antidepressants. And one antidepressant that has been really exploited when it comes to these psychogenic seizures is sertraline. So sertraline is one of the agents that has been investigated and realized that it's helpful in aborting some of these seizure-like movements in these patients.
Okay, thank you.
Any more
Dr.
questions?
Shak.
Yeah.
Yes. My question is, growing up, we heard that epilepsy runs in family. I want to know whether epilepsy is genetic.
Yeah, so in terms of the causal relations, there's the genetic component to it. So you can have genetic influence, especially if your first degree relatives have it. There is that chance that you may also be epileptic. So there are certain gene mutations that have been implicated in epilepsy.
Thank you.
Any more questions?
Taisha,
Yeah.
with respect to the surgical procedures, I remember reading somewhere that there are some devices that they use, some implants that they put inside such patient to produce some form of normal rhythm, so that it overcomes the abnormal rhythm to control the seizures. I don't know if like it's common if such things are done here in Ghana or
I'm yet to witness any of these surgical procedures being done for epileptics. All the cases that I've seen were managed by these drugs. Not had any instance where they had to go for surgery.
okay.
So maybe there are some of these things that you are talking about, but I'm yet to witness some being done.
Okay.
Dr. Ishak, please, when you were talking about the management for some of the types of seizures, you mentioned one with it was fusimide, sodium valproate, and lamotrigine, but I couldn't hear which type of seizures it is. Could you please let me know the type? Thank you.
So that's absence seizure. So the preferred first line is itosuximide. You can also do sodium valproate and lamotrigine.
Yes, please. Thank you.
Okay. Any more questions?
Dr. Ishak, you also made mention of the fact that for the miscellaneous agents, levetiracetam, the glycoprotein 2A, you said it enhances something, but I didn't hear you well. Could you come again, please?
Yeah. So I was saying is a synaptic vesicle glycoprotein 2A ligand. So hello. Hello.
Hello, Dr. Ishak.
Yeah, I think you
Yeah,
went
what
off.
question were you asking?
I was asking what you said about the glycoprotein 2A enhancing something. I didn't get you at that part.
Oh, okay. So I was talking about the fact that levetiracetam is a synaptic vesicle glycoprotein 2A ligand. So it binds to that protein, that glycoprotein. So synaptic vesicle glycoprotein 2A. So once it binds to that, it enhances the GABAergic activity. So that's the inhibitory effect. But aside that, its additional properties is able to block the calcium channels in the brain.
Yes, sir. Thank you.
All right, so if there are no more questions, we'll end here. I think I'm here to teach the online class stroke. So hopefully our next meeting, I'll meet the online class. If there's no other question, we'll end here. Have a good afternoon.
Thank you.
Thank you, Dr. Ishak.